Hello and welcome to the latest Royal College of Speech and Language Therapists webinar series. Today we'll be talking about COVID-19 and telehealth. I'm delighted to be chairing this webinar, which is so very important, especially during the current pandemic. Telehealth is certainly a new innovation for many of us, and I'm also aware that there is a small group of pioneers who've been doing it for a long while, and we're looking forward to hearing from them today. I think speech and language therapists are embracing telehealth and many other innovations during this time. And I think it's important that we hear today not only from people who are experts in the field, but also people who have learned to embrace it recently. And I think that's really going to add to our ongoing learning. The Royal College of Speech and Language Therapists have been working at pace and has just published the first version of the telehealth guidelines, which has been extremely well received. We're also working on further guidance around risk feeding and around student placements. And I suspect that telehealth is an evolving field that we will all be working with for a long time to come. Can I have the next slide, please? Just to introduce myself, in case you don't know who I am, I'm Judith Broll and I'm the Director of Professional Development at the Royal College of Speech and Language Therapists. And we're also so lucky today to have a fantastically skilled and knowledgeable panel. And here they are, and I will introduce them in a minute. These panelists have been working with us to write the college guidelines. And I would like to thank all of you. Thank you so much for all your time and effort and energy to be able to deliver the work at pace and of such high quality and volume, and especially on the webinar today. So I would also like to introduce today Rebekah Davies, who's got a hugely long and complicated job title, which is Digital Health Clinical Practitioner, Speech and Language Therapist, Dysphagia, Head, Neck and Voice at Rotherham NHS Foundation Trust. And her colleague Rebekah Radford, who's a clinical specialist speech and language therapist and clinical academic speech and language therapist at Rotherham NHS Foundation Trust. I'd also like to introduce Ellie Jones, who's a speech and language therapist in stroke therapy services team at East Lancashire Hospitals NHS Trust. I'm also joined by Shermeena, Rabbi, who's consultant speech and language therapist and founder of Unlocking Language, and her colleague Meera, Mehta, highly specialist speech and language therapist, also working in Unlocking Language. And all of you are going to be helping me and you to help answer the questions at the end. I'm now going to hand you over to Rebekah, who's going to just talk you through the housekeeping.
Hello, everybody. There will be a question and answer session with the speakers today after the presentations. If you'd like to ask a question, please submit these via the Q&A button at the bottom of your screen. Any questions that we don't get an opportunity to answer during the live session today will be made available on the RCSLT website after the event. This webinar will be being recorded today and will be available online again on the RCSLT website early next week. After this webinar has taken place, you will receive a survey. Any feedback is gratefully received, so if you could kindly fill that in at the end, we'd be very grateful. And I'll be on hand to help with anything today, so if you'd like to get in touch with me, please use the chat function again at the bottom of your screen. Handing back to Judith now.
Thank you, Rebekah. Just to clarify the aims and objectives of this webinar, by attending today, we will all, including me, I'm looking forward to learning a lot about this, be gaining an understanding of the evidence base of telehealth, also getting started with remote consultations, understand remote dysphagia assessments and assessing risk, and hearing new to digital, the speech and language therapist and service user experiences. And then there'll be a chance for questions and answer at the end. So without any more words from me, I'd like to hand over to Rachel, who's going to be talking to you about the first part. Thank you.
Thank you, Judith. Yes, I'm going to be just going into the evidence base within wider health and speech and language therapy. My clinical academic internship is research into telehealth, so this research has really come into its own now, so hopefully I can share some of what I've learned to underpin what we're now doing. So next slide, please. Just looking at the wider evidence of telehealth, there's a really comprehensive systematic review that just goes into what clinical areas there are randomized controlled trials from that have looked at effectiveness, acceptability and cost benefits. Overall, within these areas, you can see that cardiovascular disease, diabetes are very high up there internationally on how they've used telehealth. And overall, health outcomes are comparable. Cost, there's not enough data about that, but the effectiveness seems to depend on the severity of the condition, the trajectory of the disease, the sort of function of intervention. So there are a lot of factors that affect that, but overall, across healthcare, health outcomes seem to be comparable. It's a really comprehensive study. But what about speech and language therapy? So we'll have a look at the next slide, please. So with telehealth in general, is a wide base of evidence. Within that, speech and language therapy is quite small, or a small profession anyway. But there hasn't been telehealth research into every area of speech and language therapy by any means. So here we've got an idea of what areas we've seen in the world of adults and paediatrics. There are also studies that look at students, like trained in communication partners and their interaction with clients, and doing remote video fluoroscopies linked with dysphagia. But most of the studies are in the US or Australia, which makes sense because they are large geographical areas trying to provide services, and so have got very good at this. Within our guidelines, the telehealth guidance, there's an evidence-based practice section, so we've linked to that here. And a lot of this information comes from these systematic reviews, but there's some really good resources in the guidelines. There's a huge Excel spreadsheet full of different areas of speech and language therapy. There's predominantly more literature on outcomes rather than assessment. Assessment is a smaller area within the telehealth evidence base. But yes, and within the systematic reviews, they are basically saying a lot of the evidence is positive, but with relatively low or moderate methodological strength. Whereas that first slide with the wider telehealth evidence was all randomized control trials. They're basically saying that we lack that within speech and language therapy. But if we have a look at the next slide, please. But telehealth within speech and language therapy is not all new to us in the UK. There's some examples here of areas that have pioneered using telehealth in speech and language therapy. Airedale have an amazing telehealth service generally for healthcare, but also for stammering therapy. And Steph Burgess at Airedale has done a really good YouTube video on how to get started in telehealth, which is really good. We've got the remote dysphagia assessments that programs that are run out through tele-swallowing. We've got some examples of where telehealth has been relatively well established in Scotland. Again, a wider geographical area where people need access to specialist services. And also within stroke, we've got some great evidence on remote therapy versus face-to-face therapy. So yeah, we have things to be proud of, certainly. So what are the benefits and the barriers that we know about from the evidence? So if we have a look at the next slide, please. So within the service user experience, what is our experience of benefits and barriers according to the literature? Well, telehealth can certainly improve access to services, and I've referenced at the end the Airedale Stammering Service, who are providing a national service where disability services don't exist. And we've seen that they've got reduced time, reduced costs and travel time, reduced time off work for themselves or a family member, and there's strong evidence to say that service users can get their goals met and establish a good relationship with a clinician. The barriers are, there's not a huge number of barriers in the literature, in that the main thing is either lack of appropriate technology or trouble with having the right IT support to troubleshoot issues. And I'm sure people who are new to this or established in it have found have experienced this personally yourself as well. But what about the clinician? So the next slide, please. So the therapist experience is quite a lot in the literature about how speech and language therapists feel about telehealth, and and also how effective telehealth is. So there are quite a few studies that say that speech and language therapists before implementing telehealth had mixed feelings initially, but certainly positive outcomes. And once it's been implemented, people are very positive about it. We have seen from systematic reviews that there are comparable assessment and therapy outcomes, which is reassuring as a therapist, that there are we have very transferable skills and creative potential for new ways of working. That it saves on time and it's convenient. It maybe reduces travel time for those going out and about in the community. And more than one study looks at the effect on rapport. And I feel like that's probably one of the things that therapists can report, that they feel like they're not able to develop the same rapport over telehealth, but the evidence doesn't bear that out. The evidence is that there isn't a great negative effect on rapport from either a clinician or a service user perspective. So the barriers, technology failure as ever, and also the lack of physical proximity, or you're reliant on a helper, sometimes like an e-helper. So if you've got a child in a school, you're reliant on somebody within that school to help that child at the other end, or maybe a parent. So you can't quite get in there. And if you're wanting to do palpation for dysphagia assessments, for example, you can't do that yourself. It does require different methods, different communication methods, style, timing, body language, cueing. We're picking up on very different cues. And some people have found that there can be local barriers to implementation, whether that's to do with technology or service design or IT provision or employer support. So there's a wide range of barriers and benefits that are reported in the literature. The thing about all of this is that none of this data, none of this evidence was gathered under global pandemic conditions. So what about in a pandemic? So next slide, please. So this very recent article says organisational case studies have shown that introducing video consultations is a complex change that disrupts long established processes and routines. We must be clear that the change is not merely installing or using new technology, but introducing and sustaining major changes to a complex system. So this stuff is not easy under normal circumstances. Next slide, please. So I'm sure for those of you who don't have an established telehealth service, my personal experience is we established our telehealth service for voice therapy initially about 18 months ago. But I know for a lot of people, you're trying to implement this extremely quickly. Well, probably within the last 11 or 12 weeks, the guidance changed very quickly, and we had to mobilise ourselves to try and deliver the same care, but in a different way. And from our experience of developing a service, the issues around governance and consent and pathways and getting the right service user information out there and choosing the right technology, for us, all of those processes took about 6 to 9 months. And then everybody's trying to implement these extremely quickly. The other difference about in a pandemic is there's no choice. We have no choice. There's no choice for us, and there's no choice for the service user. So a lot of evidence is being gathered where people have either opted in to a telehealth service or have been randomized into 2 different groups, but we don't have that choice, and we've not set this up in a controlled way. A lot of us didn't have time to train people beforehand. We were on the ground and we were trying to implement it, whereas a lot of the evidence gathering is again from services that have taken time to establish this, and we haven't had a huge amount of time to build training packages or standard operating procedures or that sort of thing. The other thing is that we are very aware at the moment of the impact of this pandemic on our own mental health and well-being and that of our service users. So anxiety is high. We have different family circumstances, very different pressures at work, guidelines that change very frequently. We may have colleagues who are absent or shielding, and things are just changing so quickly. And when you add that into having to implement so much change at once, that's a lot to deal with. And and it's tiring to do this and to do our usual jobs. In the references, I've put an article about Zoom fatigue and why our brains are so tired from picking up different cues, from changing communication styles, and also from having our personal lives and our work lives on a screen. I'm sure people are using Zoom for social reasons as well. So our lives are quite full of this sort of stuff. When we implemented our telehealth service, I was seeing the same number of outpatients in either via telehealth or in person. And now we're in a pandemic. I can't see the same number of people, just the mental load, the preparation, the other things that are going on, the changing guidelines and processing all of that, as well as that change in work-life balance if you're working from home. We just can't expect the same of ourselves as maybe we could before, and leaving time before those appointments I think is really important. But there are so many positives. Next slide please. So again, in another article, a great quote: adversity has long been an important driver of innovation and modernisation of healthcare. And there have been a lot of parallels to national adversity in wartime and advances in many ways from there. And really there are so many positives we can take from this, and that can be based on what we know in the evidence. So we've got a very digital first approach at the minute. A lot of barriers have come down, so people are able to adopt this much quicker because there's so much acceptance across the whole country in lots of different areas of service delivery. And as speech and language therapists, overcoming communication barriers is our job. It's the stuff we do. We have really transferable skills. And in one study that looked at conversational analysis and how clinicians and patients overcome barriers with remote delivery of care, it showed that clinicians and patients do work collaboratively to overcome these technological difficulties, disruption to conversational flow. So we have a lot of skills already. Also, I think the generosity and the creativity of our profession in this time has been really inspiring. The resources that people have shared, the people that I've met, a lot of the people on this webinar and through the guidelines I've met through just searching out resources. Twitter has been an amazing resource. I would recommend, if you have yourself or somebody in your team who is active on Twitter, it is a great way to find out what's going on, up-to-date research, take part in data collection. The benefits of telehealth also, in terms of inclusion for speech and language therapists who are having to stay at home for many different reasons in this, it means we can keep doing our jobs. We can also be included in our team meetings and a meeting with our colleagues remotely. A great benefit for us is we're not behind a mask. So if we have the option to put PPE on and see somebody in an outpatient appointment or see them remotely over telehealth, I would choose this because we can see each other's faces. And really, I think there is an opportunity to capture so much data and add to the UK evidence base, which is really small. I think we have so much to offer in terms of research in this area. And there are some amazing things going on already. And the Royal College survey that came out really recently, 61.2% of therapists surveyed reported that the opportunities to work, that they had opportunities to work in new and innovative ways. And 43.6% of them was more remote video consultations. And continuing this choice of methods of delivering therapy was ranked as number one in a list of statements. So I think we are ready to embrace this technology and to take it forward beyond this. There's also a survey that you can take part in, which is at the bottom there, which is to do with paediatric therapists and your experience of telehealth pre and during COVID. And so if you can get the slides and click on that link and take part, I know the therapists that are doing that would be really, really grateful. So yeah, I think there are many reasons to be hopeful, and this is really based on solid evidence that this does work. And now I'm going to I hand over to Rebekah, who's going to go through some of the practical how-tos. So how do we set all of this up? And all the references that I've quoted will be available in the slides. Thanks, Rebekah.
Thanks, Rachel. My name's Rebekah. I'm a speech and language therapist, and I also am leading on video consultations across our trust. So as Rachel's already mentioned, this has been a huge hurdle for us all as a profession. And then leading on that over all services has provided a wealth of information, experience. It's been a bit of a roller coaster, but I'm hoping to give you sort of the nuts and bolts of how we do video consultations and how the practicalities of these for both clinicians and service users might look and how you can use these. If we go to the next slide, please. So we're going to look at platforms. So it might seem really obvious, but it depends on what you've got in your organisation. So if you're an NHS or an independent organisation, you might already have subscriptions to particular platforms. There might be nothing, so that gives you an opportunity to use the comparison charts and take them back and say, you know, these are the features that we want to use, can we have a look at these? And then that will depend on your information governance and your security within your organisation to decide on the best platforms that are either used specific to services or as you know, a unified experience across all services. So check with your employer to see what's available already in the absence of you not having done any consultation so far, which I know may be the case for some of you. Information governance is paramount in considering video consultations. Things were relaxed heavily initially by lots of the guidance, both from the government and from national drivers, to just do whatever worked. That's been reined in slightly a little bit in terms of looking at security, looking what best fits the client profile that you're working with. So again, check with your organisation about what information governance is in place for you as a service specifically, and make sure that you're adhering to it at every level. Lots of information governance information is directly available through the guidelines. There's so much of it, it's impossible to go through all at once, but go through that at leisure, and it's sort of sectioned so that you can find the right information that you're looking for. So I know that there'll be an awful lot of questions specifically around this, but you might be able to find just what you're looking for by going back to the guidelines. Some of the platform requirements look at functionality. So by doing the comparison tables, it allows you just to have a quick breakdown of what does what really. So although it might not be available to you, you can have a look at what you are using versus the other things that are out there. If there is something that you specifically want to be able to do and you're limited, things like remote control access for service users aren't available on all platforms. If that's something that you really want to do, you might want to take that up with your organisation. Again, loads of information about how to choose a platform and what's best for you is available in the guidelines if you want to have a quick look there. If you want to go to the next slide, please. So technical requirements. Some of these might sound really obvious, and I'm sort of pointing out things that you'll have said, yeah, of course we need this. So you're going to need a laptop, smartphone or a tablet for the clinician and for the service user. All of these things in terms of tech requirements are applicable to both sides of the coin or the screen. So you're going to need to consider your internet connection. Better to hardwire if you can, you'll get a better connection, considering things like where your router's placed. If you're near a window, it'll suck out the window. If you've got near a fish tank, I know some schools, for instance, have fish tanks or other settings. So if the router's placed near there, the connection can't get through water very easily. So all those things actually might be a consideration in terms of where you're sitting, where your internet connection's coming from, whether it's a 3G or 4G, in some instances for some phones 5G, especially coming up in the future as well as things progress and change, these will change. Speakers and microphones, again, these are going to be either inbuilt into the device that you're using, if that's a tablet or a laptop generally, or a smartphone. If you're using a PC, it might be that you need a plug-in. So have a look and check what you've got available and make sure that you're accessing the right equipment so that you are good to go, and not get into the video consultation and realising you've only just got audio on your side, as has been the case on a number of occasions, or vice versa. You've got the webcam but no audio. So just check all those things out. If for any reason you've got concerns about bandwidth, there are some checkers that you can do. They are on the they're within the guidelines. I think there's one from Ofcom specifically, so you can go and check what your bandwidth is and make sure you're up to speed. A lot of the platforms will actually run you through for both service user and for the clinician, and check that your webcam, your microphone's working, whether your internet connection is strong enough, and that your bandwidth will support your consultation as well. So access those facilities if you can. Some are automatic, some you need to select as you're going through the login process. And the infographic at the bottom just sort of references some of those features that you might be looking for in terms of the platform and those technical requirements. The more features that you use, the more bandwidth and data. So so consider those in terms of audio, webcam, if you're screen sharing, if you're sharing access remotely, they will all use more data. So ensure that, specifically from a service user perspective, if they're not using Wi-Fi and it's data on their phone, that they've got enough to sustain across the consultation, and that if they go over, that might be at a cost to them. So just checking those things out. So go to the next slide, please. Consent and security. It's integral to everything that we do as a profession anyway, but it just adds an extra layer of it when we're doing it via a different media. And in this case, the video consultations, a lot of it is taking into account the things that we do ordinarily and just putting a different slant on it. So when we talk about locking a room or protecting a room, it's that virtual working space that you're working with. So if you've connected on a call and you've got the facility in the platform to shut that room down so that you're not getting any surprise visitors, or you're only allowing those in that you are expecting or have invited in, that will add an extra layer of security into your session. Things like blur in your background if you're in a personal working space at home and you've got photographs on the wall, or anything that would lead them to you personally in your home. Shut things down and make sure you can, or change your background and have a plainer background if possible. I'm doing the opposite today in my with my flowery wallpaper, so use that as a how not to in terms of a background to work against maybe. Close all unnecessary windows down. Something that we don't always think about because we're so busy and we have so many things open on our desktops, but these things might actually impact on your session. It might, if you've got something else open, it could be using your webcam, it could be using your microphone, and you're not aware of that, so then your consultation won't work. Or you could have another window open that's got another session happening that hasn't been closed down from previously, which we'll talk about the closing down a session. But all those things might impact your security for a session. So only have open what you absolutely need to, and at the end of every session, shut things down safely. Always clarify who you've got in the room with you. So if you've got a service user that's joined, make sure that you've either had sight of whoever's in the room with them and ask them if there's anybody else with them. Are they okay to have those people with them? It's about their consent, and then knowing who's with them, who's watching, who's got the information, just like we would in an in-person appointment. In terms of prior to your session, things you can consider are whether you've got noise, what the lighting's like. Are people, if you're in a living room, is anybody looking into your window that's likely to see anything that's on your screen? They may not seem obvious at the time, but they could impact on the security of your session. So be really mindful about who's watching, who's listening. Have you got any little people in your home that are going to be in and out? Just be mindful that this is a working environment and you've got responsibility for your service user. If you've got prompts for data to update the platform, please remember to do them, because that can impact on security. It's usually a security feature when it asks you to prompt just remember that if you do get one, it doesn't usually take very long. It might require a shutdown or a restart of your machine, but it's worth doing just to make sure that you remain secure as much as you can. Think about recording consultations. As a rule, we don't generally do it in an in-person environment. We might consider things like recording voice and how you might want to do that, looking at equipment that will support that. Usually that will be done with an additional plugin, so you're not actually recording the session, but you might be recording something that's happened in the session. Whereas for paediatrics, it might be different, and you might need to record the session so you can upload that into a a profile so that a parent can access it at a later date. Just be mindful that you've consented with whoever it is that you're working with, that everybody's aware where it's being stored and for the purposes it's stored for, how long it'll be stored for, all those sort of things, and comply with your own information governance. Again, all these infographics are available on the website and in the guidelines, so you can go and have a look at them there as well. So you can go to the next slide, please. So the next few slides talk us through the before, the during and the after the consultation. So I've touched on those briefly in terms of how to safely shut down a session. But in the first instance, we want to know what to do before. So again, a little bit about what we do, the planning, the preparation, making sure that you've prepped in exactly the same way, making sure that you've sent out the right information, the link to the session so a service user can actually access the consultation. Any materials, any outcome measures that you might want to find out beforehand, making sure that you are working in a confidential space. We've talked about closing anything down. Make sure, although I said shut whatever you need to down, that you've got your resources ready to hand. Your therapy resources need to be ready to go so that you're not having to disappear off or go and look in a drawer or find something in a file on your computer, that you've got those accessible and you can share your screen as and when that arises. We talked about getting your webcam and your audio working. It sounds really basic, but it can be quite frustrating. So just checking those out before your consultation and make sure it works is much more helpful than having to do it during the session and wasting time. As I said before, my background is probably not the best indicator of a background without distractions, particularly when you've got children who are distracted by lots of things. So the playing in the background often works. Some platforms will allow you to blur, so it'll just appear a bit fuzzy in the background, and you as a clinician will stand out more in the centre of the screen. So that can often be quite helpful as well. If we want to move to the next slide, this highlights a resource that's available. This one was made by the NHS. There are lots of examples available in the resources section within the guidelines. This just gives a really clear sort of quick guide into how to set up a session, what to do, what to expect, to decide whether it's appropriate. Is an in-person or a telephone call better than a video consultation, and to choose, to help you inform yourself as a clinician and decide what's best for your service user. It runs through the things that we've talked about already, sort of preparing, starting the consultation, and then closing down. We'll move on to that shortly. So if you want to go to the next slide, please. So for a service user, it's a lot the same of the information from a clinician point of view, checking the additional being, you're going to check their consent and make sure everything's okay with them to go ahead and have a video consultation, checking their equipment in whichever method, and making sure that they've got the link, that their data, everything that is necessary for that session to happen, you've checked out before with them. Perhaps a telephone call just to check that they have got a device that they can connect to, that they can get emails or SMSs that they can open a link from. It sounds really basic, but there are some instances where this is going to be really valuable. If you want to go to the next slide, please. Again, this is a very similar resource that we've just seen that the NHS have produced for service users or patients from their perspective. So why would they have a video consultation versus other appointment styles, how they can set up, how they go about opening their link, etc. This is again available in our resources, so please go and make use of them. There is a mine of information out there for you to access and use. If you want to go to the next slide, please. During the consultation, so we'll have touched on some of these, but verify your patient just like you would in an in-person. So checking them against their own health record, check their date of birth, their name, their address, whatever makes you feel comfortable in knowing that you've got the right person in that session with you, and just documenting how you've verified them. Again, checking whoever's in the room with them, that the service user is okay for that to be the case. And then during the consultation, this is where you can make use of those therapy resources that you've already prepared, that you've got to hand. Flashcards, digital assessments, outcome measures or scales that you might not have had chance to do before the session if it's been an ad hoc one, if you've had a telephone call and decided that a video consultation might be the way forward, and you send them a link out, you've not had quite the time to do the outcome measures beforehand, you can screen share and complete the form together. If there's the option for remote control access for the service user, they can complete it themselves. If not, you can complete it with them. So there are multiple ways of using our service users Microsoft Forms to do this, and we can send this out electronically beforehand and also collect data afterwards if we want to. But there are other options available. Again, that information is available in the guidelines. There are loads of infographics about how to do the consultation, what to expect during a consultation, and other things that you might want to consider about that in the guidelines as well. So if you want to go to the next slide, these are some of the resources that you might want to make use of and are available. So flashcards, supporting people that might have limited verbal skills, or supporting assessments where there may be a very reticent child that doesn't want to speak. They can use pointing to these and make use of these. There are loads of really lovely resources very similar to this in the telehealth guidelines as well. If you want to go to the next slide. After the consultation, it's very much the same as we would do with an in-person consultation. The difference being you might collect feedback slightly differently. So you might want to send out a Survey Monkey, Microsoft Forms, or Google Forms for collecting your feedback that will go back to whichever way that's being collected, whether that's admin or directly to you. Make sure your call's ended. We've touched on it once, but it's really important that you've made sure that you've hung up on the red. It's usually a little red screen with a telephone symbol in it. If you click on that, it'll shut it down, and make sure I always close the window down before I open another consultation, just so I know for extra security that session has ended. And then follow up in the same way. You would write up your notes using whichever patient management system that you're using, reporting it and sending that out in the same way. We're using email a little bit more, or sending attachments via SMS. So that's something that you can consider alongside signposting them to resources that might be via a link or on YouTube for exercises, for example. So they're all things that you can consider after a consultation. And I think the final slide, if you want to go to the next slide, please. These are a couple of webinars and some resources that are specific to the paediatric therapists out there. These are really massively helpful webinars that are really cued into doing therapy with children and young adults, and the considerations and practicalities of how these can work. The slides and the links will all be available afterwards, early next week, I believe. And again, a lot of this information is directly available through the telehealth guidelines. So I really hope some of that has been useful, and I'm going to pass back to Rachel, who's going to talk a little bit more about assessment and risk.
Yes, so there have been a lot of questions about dysphagia assessments, risk associated with dysphagia assessments. RCSLT has had a lot of inquiries about services that are trying to do dysphagia assessments remotely. There are very established remote dysphagia assessment services in this country and around the world, and I'm going to give some links to some of those resources, and obviously those were rolled out initially in non-COVID-19 situations, so we are aware that a lot of people are trying to do this and implement these relatively quickly. We're having to assess risk very quickly, and the processes for what we do, and training our service users and our carers and professionals in care homes, without a planned rollout of resources. But we do have our clinical judgment, and those of us who do dysphagia assessments are just trying to apply this to a different method of delivery, which has been proven to be effective. The evidence base is there for outcomes, and our service had not been doing remote dysphagia assessments before. We've done it for voice therapy only, so we've been also applying it as we go. So this is really to share our learning and the processes that we put in place to help us assess the risk, and we also had input from the guidelines, from the tele-swallowing resources that Veronica Southern and Liz Bowden have put together, and so hopefully this flowchart that I'm going to share is will be useful for trying to look at this and an overview. Also, the Royal College are working on an interactive tool for risk assessing remote dysphagia assessments, and this work is feeding into that, and that is a work in progress, and it will be coming out, but we are aware that it is an issue. So we can go to the next slide, please. This very busy flowchart is what we came up with across various different adult therapy teams, so from learning disabilities, mental health, community, inpatient, stroke teams, head and neck cancer. We just came together very quickly to try and put something together, put a decision tree together for what we were going to do. So I'm just going to zoom in on some of these and just discuss the things that we took into consideration when we were trying to figure out how or whether to do dysphagia assessments remotely. So it's certainly not an end result, and we're not experts in it, but it is just, we thought sharing this would be beneficial. So if we could go to the next slide, please. So what we have done with all our dysphagia referrals, we've done a phone appointment and then used our clinical judgment to decide if a dysphagia assessment is required, as we would normally. The reasons why we might not have thought it was required and why we might be able to give advice over the phone, some of those examples in this pandemic situation have been head and neck cancer patients without access to technology, but very soon post-surgery, who were shielding at home. We felt that bringing them into the hospital was going to be a risk so soon after surgery, and also post radiotherapy, where the risk of not being able to swallow long term was maybe greater than the risk of being seen. So there are certain times where we've carefully used phone consultations for patients that we know already. Other examples are end of life advice that we've given over the phone, or maybe handovers on discharge from hospital. And it's not that we're not going to see these patients ultimately, it's just that we're giving advice, we're reviewing by phone, and then we're going back to the beginning of the decision tree to work out whether we need to see them if we think it is appropriate. It's always up to the discretion of the therapist whether not to do remote consultation puts the patient at more harm and risk than doing it. But these are some of the things based on Burns and Ward's training that we decided to look at. So it's whether they are clinically appropriate for a swallowing assessment, medically, and are they can they access it? Can they be positioned adequately? Are they alert enough to participate? A lot of things that we would consider anyway. Any cultural, linguistic factors that need considering, and any extra things that we need to put in place. Are we able to put those in place? Any attention or concentration or cognition things that might make it more difficult? If we thought at this point that wasn't appropriate, and then it was a no, then we would go for an outpatient or home visit appointment with appropriate PPE. Can I have the next slide, please? If we thought it was appropriate, we thought, yes, we can do this. Our next decision was to take into consideration was whether we had the appropriate technology available for that video appointment. And a lot of the things that Rebekah's been through already in this pink box, the things that we would just have a think through, do they have all of those things available? Do considerations made about confidential space. Often we say to our service users, you need a confidential space, we need to know who's there. Some of those places aren't as confidential, like care homes or wards, but can they click on a link to join a call? Do they have the appropriate web browser for the software? And do we have consent? If we think that we can't put those into place, then we'll see them face to face with appropriate PPE. But our next question was, is there someone there to assist? And an assistant in this context could be anybody, a care home worker, their partner, a carer, a family member, particularly at the moment, because we're just trying to make sure somebody's with that person, and we're implementing all of this very quickly. Have the next slide, please. So if we If there is nobody there to assist that person, we made a decision that we wouldn't see that person remotely because of the risks. And then again, with clinical judgment, there may be some situations where you might, but we're weighing up the risks and the benefits. So if there is someone to assist, we decided we needed to prepare that person for the assessment. And there are established training packages for remote dysphagia assessments based on the eating, drinking and swallowing competency framework, which I've got a link to later and has just come out in terms of the levels that we're expecting people to be competent at. So we wanted to make sure that we were confident that whoever that assistant is knows the process and agrees to it. So we put in a box what we were expecting of them in terms of that they know the technology, the process for joining, that they'll be positioning the patient, that they know the emergency procedures for any choking or aspiration risks, they know the equipment needed, thickening instructions, the process of the assessment and their role, and then to consider training according to the competency framework. If we are then confident that they know that process, then within our multiple services we were sending out thickener, their appointment letter, and we developed a patient leaflet, and there are various training packages that are available, or training packages that we can develop ourselves, which is what we have done initially, and also the emergency procedures, and then we would go to conducting the dysphagia assessment. So the next slide, please. So when it comes to the training, a lot of risks can be mitigated by people, the person supporting the service user, knowing what their role is and what the risks are. So there is a link to the eating, drinking and swallowing competency framework, and really with people that are assisting, we're probably looking at levels 1 to 4 within that competency framework. And there are also, within the RCSLT guidance on the website, there are some tele-swallowing resources from Teleswallowing, the company who have developed a lot of resources. Veronica Southern and Liz Bowden have done incredible work, and they've made some available on the website. Also, a lot of what we did was based on Claire Ward and Liz Burns' work in Australia, where they've done online webisodes of all of this stuff about what people need to know beforehand and how to conduct an assessment. And also the Paediatric Dysphagia CEN are going to be running a telepractice special in mid-July that I would highly recommend, that if you are in paediatric dysphagia, you sign up to that and get more information on how this applies to paediatrics. The next slide, please. So what we came up with was a before, during and after the assessment risks that all these collective teams had found. So in trying to implement this, what had people found that were issues, and then what could we do to mitigate that risk, in advance. So in terms of before the assessment, things like not being able to connect to a call, or not being able to be heard, or you can't be seen. I mean, that would be applied to any therapy or tele-assessment. So we've just developed a list of things to check, which has just been useful, so that in the midst of trying to manage the technology and the client, and we just know what to do in those situations. Can I have the next slide, please? Also, what other risks we found before the assessment? Maybe not being able to directly obtain information from a written care plan, for example, in a care home before the assessment. So really just making sure that we'd got comprehensive information gathering by telephone with the appropriate person, and verifying the accuracy, and just checking whether there were any significant changes. So we just looked at things we were able to do before, and things that doing things by telehealth, what risks are there? Not risks to the dysphagia assessment itself, we know those risks from our clinical practice, just how does it make it potentially more complicated? If no third party was available, there's no assistant available. So if no one could be present, or you arrive at the assessment and there's no one present, then we would consider an alternative appointment format if that's a problem long term, or rearrange for a time when there is somebody available, and make sure that we send out details of what we're expecting before the appointment and any appropriate training. We've got various things that people have noticed, like the service users themselves struggling to position the camera, and just an assistant not helping them. So just making sure that we know what the role of the assistant is. Can I have the next slide, please? So during the assessment, things that people had noticed was things like Sarah's user moving out of the view of the camera, making sure that we, sometimes I've just put up with a bad camera angle and then realised that really I just need to ask somebody to move, but it's just slipped my mind. And I get used to, you know, talking to people on Zoom or FaceTime where all I can see is their nose and just putting up with it, but we can't put up with it for dysphagia assessment. We might lose connection, and so that's an issue in any therapy, but in this situation we might lose connection and they're eating and drinking something that has put them at risk. And this came from an actual example of loss of connection, where once the therapist reconnected, the client had eaten some level 7 contraband diet whilst off camera. There's a potential reduced privacy or confidentiality compared to what we might do if we were seeing people face to face. So it's just finding a quiet setting without distractions, checking who else is present, as Rebekah was saying before. And another example we had was when someone chose to end the call themselves, which is their right to do that, but we just needed a process in place of how many times we would attempt to reconnect and contact them to rearrange an appointment or an alternative method of appointment. And the next slide, please. So sometimes we've had people who weren't prepared, so they'd had everything sent out, but it just wasn't to hand. So we just wanted to make sure that we put that in our information, and maybe arrange training, and definitely arrange training beforehand. A lot of these things could be mitigated by having appropriate training in place, but we didn't have a lot of time to formalise that, and it is something we're looking at doing in the future. But so again, just rearranging the appointment rather than sort of muddling through. We just wanted to get it right. There is a risk of missing adverse signs of snoring problems when you're not there face to face. You can't hear breathing, can't palpate, and or maybe hear changes in respiration. But again, this could be mitigated by training, but also we wanted to make sure we had that in our advice, and to make sure that we were asking questions throughout to support observations and just prompt to say, what can you hear? Can you hear any changes in this? Can you hear any changes in that? Could I have the next slide, please? We also looked quite closely at emergency procedures that we felt were important for people to know, as we can't quickly intervene ourselves in a choking incident or intervene in another medical emergency, but we still have a duty of care because we are in a consultation with that service user. So we sent out details of all the essential requirements, important information, and we contacted the resus department within our trust to ask what information would be the best and most up-to-date to send out, and they recommended the St John's Ambulance information on their website, who have great PDF documents and videos on there. So we decided to send out that choking advice, and also just set those ground rules about if we give instructions to stop eating or feeding, or feed more slowly, that they're aware of what to do in response to that. And also we've made sure that we have a local choking script so that we can read out what they need to do now. So if they haven't got things in front of them, that we could do that, and then we would agree in advance who was contacting the emergency services before that happened. I mean, face to face, I've rarely had to call an ambulance for anybody, but we need these things in place. And also just checking at the beginning that they've received all the information, that they're confident and they've got all the choking advice, and set all of that up. And then the next slide, please. So after the assessment, some of the risks that we identified was just a confidential incident if a clinician forgets to end a call, as Rebekah said, and also just not being immediately able to provide written documentation regarding the outcome of the assessment, or handouts for recommendations. So we make sure we provide verbal feedback and call another appropriate person. If there's someone who's not there but needs to know, we'd call them straight away after the call, and said we've turned all our advice into electronic versions, and we anonymise those so that we can send those securely. As Rebekah said, there are secure ways to send this via email, so from NHSNet email, if a lot of our care homes have got NHSNet set up, or we can now, some platforms will let you text documents, so we anonymise those documents and text the link and again, we'll follow our local procedures. And the next slide, please. So we tried to develop some infographics that would just help us look at the process for remote swallowing assessments, which is based on the training that we did with online, the Warden Burns training. So the process for the swallowing assessment, just as a reminder of what we're doing and when. I mean, we know how to do a swallowing assessment, those of us who do them, but it just adds an extra dimension that means that I find that there are things that I can forget because I'm trying to, you know, navigate the technology as well, and also just the role of the assistant as well within that. And these will be available on the telehealth guidelines in the near future, very soon, hopefully. And the next slide, please. So within our service, we developed some infographics for patients as well, just to go within a booklet with our emergency procedures, and of how to prepare and then what to expect, so that they know what we need beforehand and what to expect during the assessment, just as almost like a prompt, so that they know what we're doing. And on the next slide, this is just an example of what we've sent out to people. So just a booklet, instructions on how to pick in, and then our recommended advice on emergency procedures. Yeah, so that we thought that was worth sharing, but there is going to be a RCSLT interactive tool to go through all of these risks, and there is training out there and some really, really good resources. And the next slide, I think, is me handing over to Ellie and Meera, who are going to talk about what it's like to be new to telehealth.
Thanks, Rachel. So I'm just going to give you all a bit of a narrative about my own personal experience as somebody who is new to telehealth and conducting teletherapy. So I've been conducting teletherapy for just over probably 3 months, or just about 3 months. And prior to this, I carried out therapy in the traditional face-to-face way, so either in people's homes or in nursing homes, residential homes, or as an outpatient appointment. My initial reaction upon first kind of getting used to teletherapy or first hearing about it was curiosity, really. So I wondered, as many of you probably have also wondered when considering something new, how's it going to work? What can I expect? Is it going to be as good as face-to-face therapy? How do I do things via video? Is this going to be detrimental to the service user because it's not face-to-face? Is it an equitable and realistic service for all the service users? So before I actually started the teletherapy, I had a look at various resources and lots of sources of information. So that included things like articles and research that I've found, information on NHSX, sharing platforms such as Slack, something that had been set up during the Covid-19 period for speech therapists, and had lots of various information. And I also found, like Rachel and Rebekah have said, lots of really useful information on social media. So Twitter had lots of people talking about their first experiences with teletherapy, and also there were some teletherapy groups that had already been set up on Facebook that you had to request access to, but they also had some really good ideas. And during this time, I found that there was various different ways that people were working and different video calling systems that were being used. At the time, I was aware that the trust that I worked for was in the process of setting up a system and using the video system that linked to our clinical notes. So whilst waiting for this system and the go-ahead to kind of get going with teletherapy, I began to develop some guidance that could be used when we were all ready and set up by the speech and language therapy team in the trust. So during this time, a colleague and myself put together a consideration checklist on the type of things we would want to question for those we were considering. So those who we felt may be suitable for teletherapy, what types of questions we'd want to know about it, with the long-term aim of developing some further resources and perhaps a flow chart or a decision-making tool that could help when the teletherapy service kind of picked up in the future. So we began to start trialling some, but limited video session calls initially between ourselves. So me and some colleagues kind of had a practice before we actually tested it out on patients. And we began to develop some more guidance on how to conduct therapy, mainly around dysphagia, as this was an area that people were really concerned, and how we were going to carry out swallowing assessments and swallowing therapy through a video. So that's where our main focus was, but we're also starting to use therapy, the teletherapy for our communication patients as well. So during this period, I came across a tweet from Claire Burns, where she had a suggestion of this up and running e-learning programme from Queensland Health about telepractice dysphagia assessment, and she'd said that RCSLT members were able to gain access to this. So I tweeted Claire, gave her my email address, and had a prompt reply with details on how to set up and access the training, and just to see what they were doing when they've been conducting the teletherapy sessions. So once I completed the training, I made some notes and felt that things that were going to be relevant to the practice and the trust, and used the guidance kind of that they'd been using and kind of merged them all together. This alongside like other bits of information I found along the way from research and various articles. And I've initially developed some guidance for the speech and language therapy team at my current trust to use. So that looked at both home dysphagia assessments carrying out in nursing homes, residential homes, and also within the hospital setting. So following developing the detailed guidance, I then went on to develop a simple flow chart to go alongside the detailed guidance to make the task of doing teletherapy a little less daunting, as I know for myself it was really daunting to start initially and to kind of just get the ball rolling. So we then carried out some initial sessions, and through trial and error with the team, we've made changes along the way, and now we've got the RCSLT guidance. We've been changing different things, so tweaking certain elements throughout. Just go on to the next slide, please. So through carrying out teletherapy, the initial therapy sessions I had with the patients for both swallowing assessments and communication therapy was extremely nerve-wracking, but I loved the way we were being challenged to change the way we were working in the current times. So I found dysphagia assessments more nerve-wracking than the communication sessions, because I felt there was a higher risk element to these. However, I was confident that with suitable criteria and risk assessment for service users who I felt would benefit from teletherapy, compared to those who, like Rachel has been saying, risk assessing in terms of those who aren't suitable and are going to need a face-to-face or other methods. I felt confident in carrying out some dysphagia assessments via teletherapy. To further reduce the risk and to ease the flow of the session, I'd always ring beforehand, speak to either the service user, somebody who's with them, a family member, or somebody, a staff member who's been looking after them. And I would send either in the post or via email details of what to expect beforehand, how best to set up and prepare for the teletherapy session, how to access the system we were using, and just things that they could do to make the session run a bit more smoother, ultimately trying just to reduce the risk throughout. So things that I've found during teletherapy sessions, I've enjoyed the flexibility in scheduling service users while knowing that I don't have to commute from patient to patient, and this has allowed me to plan more for each patient and it's made each session a bit more personalised. I think overall people, once they're over the initial fear of therapy, have felt very relaxed and comfortable. Care staff have been really understanding, taking on this challenge, and families have been really great in supporting us, because they know what's going on at the moment, just to carry out video calls, and slowly it is starting to feel like the new norm. And I think with people now using video calls, video families, I think we may be making that leap forward with technology, and with the RCSLT guidelines, I feel this new forward way of working, providing therapy via this alternative method will continue to improve, and just allow an equitable and effective service to the speech and language therapy services for all. There are, of course, like anything else, there's been its disadvantages, perhaps noticeably the most notable being technology glitches, such as inconsistency in internet connection, frozen screens, echoing, video feeds and drop calls, which aren't helpful to the therapeutic experience. But again, therapy service users have been really understanding and patient with the team. Another disadvantage, and which I think a few people probably have questions about, and something we're looking at within our own trust, is those patients who would require a translator during the therapy session, and I think those patients who are severely aphasic or have a severe cognitive impairment, this has made it harder to carry out teletherapy, and trying to engage people in video calling. I think more so with an elderly population, they've had real difficulties in actually having access to this technology. But we've found other ways, either by calling them or trying to send out therapy in the post to kind of counteract the fact and try and keep them involved in the service. But I think overall, I think people do feel more comfortable in their own home, and at certain times I do feel quite comfortable having the video call with them in my own workspace. And the patients I've worked with have thoroughly enjoyed the sessions. And although therapy isn't the same, it's allowed me to be more creative with the therapy sessions. And like I say, it allows me to add a personal element to the therapy session, whether that's through the PowerPoints I use or the types of resources I use, which has been really useful. I'm going to the next slide, please. So just some tips for people who are starting or have just started to use teletherapy. I think my number one tip would be to prepare and practice. So make sure you have everything you need for your session ready beforehand. Make sure the area you're in is clean and the computer and devices are loaded up with all the right systems open. Make sure the patient has everything they need as well, just to help the sessions flow better. So like I said, we've been making little packs and sending them out in the post or emailing them beforehand. And I often ring beforehand as well, or text, just to let them know I'm about to send them a video link. I think one of the best things we did as in our team is we practiced between colleagues, just so we could make sure we had the camera set up right, we knew what the area needed to be like, we knew how to get the volume right, making sure that the background noise is minimalistic and the background behind you is not distracting, and just consider positioning your camera against things so that it's not distracting, like Rebekah and Rachel both said. Managing risks, so using the RCSLT guidance to plan and to see, is this the best throughout, but it's really also important for the patients to know this as well. So where possible, just keep hydrating and drinking lots of water. And finally, I'd say don't worry, try not to be nervous, relax and enjoy yourself. Most of us are new to this, and most service users are new to this, so don't worry if things go wrong. You can allow for mistakes. It's a new way of doing therapy, so it gives you time to think a bit outside the box of how you're going to carry out your therapy sessions and go from the old norm of doing things and introducing a new norm and trying to engage in therapy sessions that way. Go on to the next slide, please. So this is just some of the one of two reflections from one of our service users who at East Lancashire Hospital Trust, who was working with our community speech and language therapy team. So Wendy supported her mum using teletherapy for swallow assessment, and I think also some communication assessment. So she's had 2 sessions of teletherapy with a mum, and overall found it was a very positive experience. Like a lot of us will have experienced, there was a few teething problems with accessing the link, but once this had all settled, they managed to collect the calls and they went well. Communication was clear, and they felt the method was an effective way and much better than just having a telephone call. Wendy felt like she was able to move the camera around so that she could assist as much as she could in the swallowing assessment, because we aren't there to palpate, and it was just made it easier to see if they just get a better vision on things. And they said they would gladly use the service again and would rate it 9 out of 10. So that was really positive to hear, and something that was great for our community speech and language therapy team to receive. Just on the next slide, please. So again, this is another service user who works with our community speech and language therapy team, and it's a video of Ian's own experiences and how he's reflected on using teletherapy. So if we could play the video, please.
My name is Ian Taylor. I'm 64 years old. I've had Parkinson's for 17 years. And 8 years ago, I had the deep brain stimulation operation, which has made a huge difference to my life. Parkinson's is still going on in the background, and as a result, I felt my swallowing and speech was slightly deteriorating. I was referred to Burnley Speech and Language Therapy by an ENT consultant. Due to the Covid-19 outbreak, I was offered teletherapy, which I thought was amazing, as there would have been a delay in me receiving treatment otherwise. Barbara assessed my swallowing via video and provided me with helpful information and asked me to complete a food and drink diary. Any problems, she advised them to try and overcome them. I was also provided with the swallowing advice level 7EC for Irish foods. As a result of this advice, I have adopted my eating and food preparation, and I have found this has helped my potential swallowing problems. Without the video therapy sessions, I would be weeks behind waiting face-to-face consultation, and at the time, no one knew how long that would be. I found accessing these sessions by video link very easy. Still using the video link, I started the exercises for speech improvement. However, with Lauren. However, due to the relaxation of face-to-face sessions in the garden, I am continuing it all on a one-to-one face-to-face basis, and I personally do prefer this. Having said that, I will not just dismiss the video therapy if circumstances are to change again, as being supervised by any method is better than having none at all. My name is Ian Taylor. I'm 60.
Brilliant, thank you for that. I'm now going to pass you on to Meera, who's going to share her own experience about using teletherapy as a therapist. So Meera, I'll hand over to you.
Thank you, Ellie. So this is a video we're going to show you of my client Archie with his mum supporting him for weekly speech and language therapy sessions via teletherapy. Archie was referred to our service in April 2016, and since then he's been receiving regular one-to-one weekly speech and language therapy support in school with his teachers and learning support assistants also helping in the school setting. Archie has cerebral palsy and increased muscle tone in all 4 limbs. He presents with contextual understanding, including understanding of concrete instructions, and is at language for thinking level C, which means that he's able to select information that's presented to him and combines it with the experience of the world around him. He's able to organize his thoughts into logical sequence, but sometimes shows difficulty to express these. he has started to make simple inferences and predictions. So for example, tell me how the children planted the seeds. How does Susie feel? What is something you shouldn't do with books? He uses verbal language to express himself, and that is his preference of communicating. However, he does also continue to use his AAC. He's making good progress with the device, but doesn't always spontaneously use this. Since the school closure, Archie has been accessing weekly speech and language therapy sessions as we would on a regular basis, but this has been via teletherapy, via video platform. We've ensured that he has still been able to carry out and continue working on his targets, making sure that the EHCP provision that he does have doesn't stop. Thank you.
Could I ask you to move Archie a little bit to the other side? Yeah, I can only see half of him. Let's see if that's better. Yeah, great. Now we're going to identify the where in the sentence, okay? So I'm going to read it out to you and I want you to help me spot it. All right. So by the way, I forgot to tell you, you've earned your first star, okay? And I'm writing it down, and at the end, you're obviously going to get your stars, okay? Yeah. Okay, tomorrow, Sam is going to the beach. Where is he going? Well done, he's going to the beach. Okay, I have some pictures here, okay? Yeah. I have different pictures that we might see in a safari. Okay? I've numbered them. Let's circle or draw a line under the striped animals. Can you number the striped animals for me? Numbers animals. No. Well done. Good. One. Say that again. So you said one. One. Four. Four. Good boy. You know when you're not in school at the moment. Why are you not in school? And what about, you know what I know we see you on a Friday in school, yeah? Every Friday I come in school. Do you like that I still see you on the computer and we do activities together? Is that a yes or no? Yeah. And I'm going to ask your mommy some questions now. Is that okay? Yeah. I don't know. Just a quick question. So, just in terms of kind of the speech and language therapy provision, how do you feel that this is still continued out of beginner school? Yeah, yeah.
Okay, I think that video has frozen. I'm going to pass it on to Judith for further questions.
Unmute, I can do that. Thank you all so very much for that hugely insightful and detailed account of how telehealth worked. And I have been listening really hard, learning a huge amount, and also trying to keep up with all the really dynamic chat on the questions and answers. I think there's lots of themes emerging, and it's quite hard to know where to start, but I can see there was quite a big theme around in a long conversation, especially around what platform to use. And I know that it looks like it depends on where you're working, but I'm just opening up to all the people on the call. Maybe start with you, Rebekah, seeing how this seems to be something you know a lot about. I don't know if you were able to read the information that was, or the questions being asked, or have you got any comments about what questions you were getting around what platforms to consider, especially around groups, maybe? You might need to unmute.
Sorry, I hadn't quite clicked it. The groups come up quite a lot, and although I've worked with groups in other services, it hasn't been one as yet that we've addressed in speech and language therapy specifically. That's not to say it wouldn't be appropriate at some point. It is possible. There are a number of platforms that will support group working. Teams, AccuX, Attend Anywhere are all the ones that our own trust uses. There's varying levels of numbers that you can have within that, so it depends how big a group, what is it you're wanting to achieve. There are some extra consent issues in terms of how the link is sent out, so ensuring that if you are sending a link for a joint AccuX conversation, for example, that link will be the same for everybody, but you will need to send that out on separate emails. Otherwise, if you send it out on a group email, they would all have access to everybody's email address. That's the same for sort of Teams as well. So just considering how you're sending things out. But other consent is pretty much the same if they're expecting to come to a group, knowing that they'll be interacting with other people. All these things are possible, and sometimes it's just a case of trying things out and not being too scared. If your service users are willing and know that this is a possibility, a lot of this, although another theme has been around digital poverty and access to hardware, many people in some respect will probably have had access or joined a call at some point, been part of Zoom socially, as Rachel mentioned a number of times. So these are things that aren't within the realms of possibility for lots of people, and they probably won't be too reticent in saying, yeah, we'll give it a go. So it might be just a case of looking at what it is you're actually wanting to achieve, checking the features of your platform, and then looking at how you might proceed in terms of inviting and the objectives of that group. But if anybody else wants to add anything, please feel free.
I was just going to mention, in the private practice world, therapists are using Zoom, Google Meets, and again, just as Rebekah said, I think it's considering looking at differentiating the consent form, thinking about confidentiality, the risk assessment also that would be adapted for when we're doing group therapy. At our practice, we have started doing paired therapy, which has been quite interesting, because of course you're going to have both sets of parents present with the child. So it's just thinking about safeguarding and a risk assessment when there are 3 or 4 children in addition to 3 or 4 sets of parents.
I also need to learn to unmute. Thank you for that. I also see, can I just pick up on that point around digital poverty in a wider sense, Rebekah, because I think that is really important that we do acknowledge that there are some families in particular. We've been talking to clinicians working in inner London schools, for example, and inner London services, who are saying that some of the parents don't have the data allowance to be able to do this work, who might not have the equipment to do the work. And I think you're absolutely right. This is really important that we acknowledge that, and it's something that RCSLT is going to take forward to look at with the BBC, interestingly, but also taking it back to government to highlight. So I absolutely hear what you're saying on the chat, and thank you for raising it. It's something that we are aware of, but should the information be available and the data be available, all the information to date is extremely valuable. There was also some questions, quite a lot of questions in particular, about learning disabilities and with adults working online and with other services. Before I open that for some comments from the participants, can I just comment? I hope people know, or I only heard this morning, so I don't know how wide it is, that the Stroke Association has just recently today brought out some guidelines about how to work online, especially to support adults with aphasia, because they appreciate that that is a really complicated area for people with language disorders. So going back to learning disabilities in particular, because that's something that came up on the chat, I wonder whether anybody on the call has any comments about or experience of working with that caseload with telehealth. Is that
I don't have any person. I've worked with adults, but haven't worked with learning disabilities. But I have consulted with some of our colleagues who help with the guidelines who do, and I think it's about making sure that there is enough support around that person for them to be able to access it. So in the same way that we might train an assistant with one of our service users, I think just managing expectations and the role of the amount of support they might need to access that. I think Meera's video kind of shows that clients who in one context might struggle to see their therapist in a different format, like Archie, who he is used to seeing Meera face to face, and then it's very different on the screen. But from what I understand, Meera, he had adapted pretty well.
Yes, that's right. And he actually thoroughly enjoys the sessions as well. So initially he was a little bit shy to see me via video, but then got used to the idea that actually every Friday I used to see Meera in school. Nothing's changed. I'm just going to see her via video. And in terms of how you talked about the learning support assistants in school or teachers in school supporting children, it's now where the parents are taking on that role, and we're using our knowledge to skill up the parents and educate the parents around specific strategies or targets that we would use with their children.
Thank you. That's very helpful. There have been a lot of questions around the evidence base of this work, and thank you for the presentation earlier, Rachel, and putting together some SOPs around that. And I just wondered whether, as part of the presentation, if there's anything within the telehealth that would help with that.
We do, in terms of SOPs for using different platforms, we do have example ones of those in the information governance section on the telehealth guidelines. Also within the evidence base, there's some really comprehensive charts of just Excel documents full of evidence that's been gathered, and across paediatrics and adults and in lots of different areas. So there's certainly resources there to go and have a look at, find your client group and look and see what evidence there is, and look at the example SOPs and data privacy impact assessments and all those sorts of things that might just help you with getting that sort of thing through and getting it approved by your employer. There's definitely a good evidence base, and if you can't find what you're looking for, definitely put things out on Twitter or contact RCSLT, and we're looking to get I know that they're in the process of developing a forum for telehealth and sharing resources, so that will be coming in the future, but I think that will also be a really good place for sharing those things. So if there is anybody who has developed a case or a SOP or a good evidence base within their area that has been successful, or a business case, then and you're willing to share those, it is great to have RCSLT as a forum to share those things.
Absolutely, we are going to be collating that and all the sharing is starting already here, so I think it's something that we can just take forward in the future. Something else I just saw on the chat was a lot of information and interest in the student placement telehealth work, which is starting up shortly. I'll be coming to pick your brain, Rachel. I saw you were already involved with that, but I think we're getting that started next week. So if anybody is interested, we're going to put out some some calls for expressions of interest to put that work together as well. So this is a call to arms from everybody. So I'm sorry to use this platform to do it, but I thought as I was here I may as well, and that will answer those questions. I'm also very aware of the time. There's been so much to talk about, and it has been fabulous. So what I would like to do first of all is to thank all our speakers, and I'd also like to thank Ian and Archie in particular for offering their themselves up for this talk. As Rebekah said at the beginning of this webinar, all your questions that we haven't had time to answer, we will absolutely go away and review, and we will send out something to you in the next week or so. I really would love to thank Rachel and Rebekah and Ellie and Meera and Shermeena for all their help today, and I'm sure you will join me in thanking them for their time and their insight. I feel like I have a lot to learn and a lot to think about. So I'd like to thank you all very much, and I think I'm handing back to Rebekah for a final word before I say goodbye.
Hello, thank you everyone for joining today. Just to reiterate that any questions that we didn't get around to answering, we will be putting those on the website along with a recording of the webinar today and also the presentation slides. And thanks again to all the speakers. Have a good afternoon.
Yeah, thank you. Bye-bye.